This webinar provides an overview of how London Protocol is used in the New South Wales health context. I would like to acknowledge the traditional custodians of the various lands on which we work. I pay my respects to elders, past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. This webinar gives high-level guidance on London Protocol. We encourage you to first listen to the Changes to Serious Incident Management in New South Wales webinar on the Clinical Excellence Commission website or YouTube channel for an overall understanding of serious adverse event review requirements. London Protocol is one of 4 approved methodologies used in New South Wales. For each Clinical Harm Score 1 incident, the Chief Executive determines the review method to be used. Regardless of methodology, all review processes seek to answer 3 key questions: what happened, why it happened, and what action we can take to prevent it happening again. At the Clinical Excellence Commission, we've structured all of our resources and training around how each review method addresses these questions. Systems analysis of clinical incidents, otherwise known as London Protocol, was developed by Charles Vincent and Sally Taylor Adams for the healthcare context. The concepts are easily understood by clinicians. It takes a systems approach to incident review and calls out care delivery problems and any contributory factors. Let's look at a couple of definitions. Care delivery problems are ones that arise in the process of care, and they have 2 defining features. Firstly, care deviated beyond the safe limits of practice, and secondly, the deviation had at least a potential or indirect effect on the outcome. Care delivery problems are fairly easy to detect, but some examples include failure to adequately monitor a patient or escalate when their condition was deteriorating, or a failure to act upon a test result. There may be many factors that contribute to a single care delivery problem, and London Protocol has a table with typical contributory factors that are grouped into patient, task and technology, staff, team, environmental, organisational and contextual factors. This is the chronological mapping of care delivery problems and associated contributory factors table. A team completing a London Protocol review follow the steps in the process and populate this table as they go. So there are 11 steps that the Serious Adverse Event Review team follow to complete a London Protocol review in New South Wales Health. However, when seeking to figure out what happened, the team follow 4 steps. So prior to the first meeting, the team leader will review all facts, knowledge and documentation related to the incident, including the medical record, the incident report, the preliminary risk assessment and any other relevant documentation. If the incident was an inpatient fall, the team leader will complete a falls factor analysis. The team leader will construct an initial flow diagram of 5 to 6 boxes outlining the chronology of events. All of this information is then shared with team members and who are asked to review it prior to the first meeting. And it's at the first meeting that the team review the data and finalise the sequence of events. So this is the falls factor analysis tool that's completed for inpatient falls, and you'll find this in the London Protocol toolkit and workbooks. The team then review the incident chronology and at each step determine if there were any care delivery problems arising in the process of care. The team establish who they need to interview to find out more about the care delivery problems. Questions are developed and interviews are allocated to individual team members. The team undertake interviews with patients, carers and families as well as staff. One of the key tasks of a review team member who's interviewing a staff member is to establish a safe environment where staff feel free to speak and have the ability to recall what happened. In setting up an interview, the team member needs to explain the boundaries of review, letting the staff member know that we're seeking to improve systems of care rather than apportioning blame. They need to also explain how the information gathered will be used, what will happen after the interview takes place. During the interview process, staff are also invited to identify care delivery problems as well as their contributory factors. The interview is complete, the team come back together to review the information that was gathered and confirm the incident chronology. A team completing a London Protocol review undertake 4 steps to work out why an incident happened. Step 5 in the process is to identify factors that caused or contributed to the incident. The team review each care delivery problem and brainstorm the contributory factors using all of the information gathered. Some teams may choose to present each care delivery problem in a fishbone diagram with the care delivery problem stated as within the fish head, and the labels on the fishbones are the contributory factor types with the contributory factors listed below. Identified factors are then listed under the relevant care delivery problem in the chronological mapping of care delivery problems and associated contributory factors table. The team then link the identified factors to the outcome to clearly define why something occurred. Factors focus on processes and systems rather than individuals. So, for example, the first factor in this table is that informal handover practices led to the wrong patient being discharged. Alternately, causation statements can be used to link factors to outcomes. In some local health districts, a director of clinical governance may state a preference for this approach to link a factor with an outcome. A causation statement has 3 parts: the cause, the effect, and the event. So using that same example, a causation statement may read as follows. So there were no procedures established or expectations regarding formal handover of identification of patients, thereby increasing the chance that patients would be misidentified. This resulted in the patient being discharged and without full review with undiagnosed myocardial ischemia. The team then determined the practices, processes, or systems that need to be reviewed. So in this case, it's handover practices in the emergency department. The team write up the findings report next, and let's have a closer look at what this includes. So the findings report includes a description of the incident and a sequence of events. It's written over 1 or 2 pages. The team identify how the incident occurred and list any underlying factors linking them to outcome. When the findings report's finalised, it's submitted to the Chief Executive, who's responsible for directing whether a recommendation report needs to follow. The findings can then be shared verbally with the family by the Open Disclosure team, and it's the dedicated family contact who arranges this. Teams who go on to develop recommendations follow 3 steps. So the team brainstorm actions that could prevent the incident or mitigate harm. And in doing so, they take into consideration any recommendations put forward by the family. The strength of each action is assessed against the action hierarchy, ensuring that at least one strong or intermediate action is identified for each factor. It's at this point that the team consult with any other services that may not be represented on the review team, and an interview letter is issued beforehand to ensure that privilege is maintained. So this is an example of an action hierarchy. This states that stronger actions are ones that are the best at removing the dependence on a human to get things right, while weaker actions are one that support or clarify the process but rely solely on the person to get it right. In other words, stronger actions look at review or redesign of processes to ensure all staff take the right action, whilst weaker ones remind staff of what the right action is. Recommendations are added to the chronological mapping of care delivery problems and associated contributory factors, which completes the table. So for each recommendation, an action plan is developed that includes a due date, an outcome measure, a person responsible, and an oversight committee. The team finalise the recommendations report and submit it to the Chief Executive for approval. When the report's approved, it's submitted to the Ministry of Health along with the findings report. So let's take a look at where you can find more information about London Protocol. So for more information on London Protocol, if you visit the Clinical Excellence Commission site, you'll find a London Protocol toolkit. The toolkit that has been developed includes step-by-step guidance on the process to follow. There are detailed instructions and examples of tools that have been populated. There are also workbooks for teams, and these have been designed for teams to work through as they meet and go through the process of review. They include a breakdown of all the steps into meetings. Each meeting has a checklist of steps to be completed, and all of the templates are empty and include instructions. There's also additional planning templates like Gantt charts, fillable forms, and so on. Thank you for listening to this summary of the steps of the London Protocol process as applied to the New South Wales health context. Keep an eye out for serious adverse event review training programs by checking in on the Clinical Excellence Commission website. Please feel free to contact us with any questions by emailing us.